Good evening. My name is Sherry Singer, and I am the American Liver Foundation's National Director of Fundraising and Engagement, and I'd like to be the first to welcome you to tonight's academic debates presented by our Mid-Atlantic Greater DC Medical Advisory Council. This educational program is brought to you by the Greater DC Planning Committee, led by Dr. Rohit Sakatsar, who you'll be meeting shortly. We are excited about our topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderator. We are grateful that you take time out of your busy schedules to join us and hope you enjoy the evening. Tonight's academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have a question, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments or to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on the ALF's YouTube website for future viewing. As I mentioned earlier, we are extremely grateful for our ongoing sponsor support. Our national sponsors have supported our debates across the country in 2021 and include national gold sponsors AbbVie and Eisai, silver national sponsors Salix, national bronze sponsors Alexion, Mallinckrodt, and Pfizer, and tonight's national expo sponsor is Exelixis. Let's hear what our national gold and silver sponsors have to say.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs, and we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications, because our mission to improve the care for GI patients continues today. For us, there is no finish line.
Before I introduce our moderator, I want to acknowledge tonight's technology team. Karen Irwin, and ALF's national team, Nancy Clemens and Eric Bachter. We couldn't present tonight's event without their support. Now it's time to turn the program over to someone who really doesn't need an introduction. He is highly regarded by the members of the greater DC medical community and beyond. Please join me in welcoming our moderator for tonight, Dr. Rohit Sadaskar, Director of Medical Services for the MedStar Georgetown Transplant Institute. He is also Medical Director of Liver Transplantation and Associate Professor in the Department of Medicine at the MedStar Georgetown Transplant Institute. An expert in hepatology and liver transplantation, Dr. Sadaskar is board certified in internal medicine, gastroenterology, and transplant hepatology. In addition to Dr. Sadaskar's role as a clinician, teacher, and researcher, he is actively involved in public policy efforts to benefit patients with liver disease. He serves in leadership positions with professional societies such as the American Association for the Study of Liver Diseases and the American Liver Foundation, and is a founding board member of a global liver institute dedicated to collaboration and innovation in dealing with liver disease. Tonight, Dr. Sadaskar will be saying a few words about the history and format of tonight's debate. And we'll explain how you can help support the mission of the American Liver Foundation, how you can promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debate.
Thank you, Sherry, and thank you to the American Liver Foundation for putting on this event again. This is the third annual American Liver Foundation's Greater DC Academic Debates. The first one we were fortunate enough to do in person. Many of you were there. It was in downtown DC. We had a wonderful venue for it. We were able to serve dinner. Tonight you're on your own for dinner. In the last 2 years, we have had to do it online for obvious reasons. But hopefully next year, we will be back in person. But thank you again for everyone that's joining us. We have a really exciting program. The academic debates, go back many years. They actually go back about 18 years that the American Liver Foundation has been hosting this. And as you know, the ASLD now also does an academic debate. Though this originally started with the American Liver Foundation. I was fortunate enough to participate in the academic debates for the first time in 2006 as a fellow in Chicago at the time, and our topic was actually regarding chronic hepatitis C, and it was whether a liver biopsy should be required in patients that have hepatitis C genotype 1 before being treated. So if you can imagine, many of you on this call probably can't fathom why we would even ask that question, but that was the question that we had to answer 15 years ago. But here we are today. The topics and teams were selected by members of the Greater DC Medical Advisory Council. We have 4 excellent debate teams today. Each team has 2 fellows, and each team is mentored by a senior clinician educator with liver expertise. We have 2 debates today. We'll have teams from the University of Maryland, Johns Hopkins University School of Medicine, MedStar Georgetown University Hospital, and the National Institutes of Health. The topics that are chosen and assigned are specifically chosen because they don't have a right or wrong answer. And they are topics that have not really been settled in the medical literature, or they may be ethical in nature and really have no correct answer. And as a result, we can present both sides of these. And you can see on the screen on the right, those are the criteria that the judges will use to grade and choose a winner. Through these debates, we seek to stimulate higher thinking about some of these issues and the issues that really impact the lives of people with liver disease. The debates are going to be fast-paced. Each will start with a debate on the pro side, presenting the pro side, which will be 8 minutes. And then we'll go to the con side. They'll have 8 minutes to present their argument. The timekeeper is going to hold you to 8 minutes. So you'll get a warning, but if we get over 8 minutes, you'll actually be cut off. So try to keep your presentations to 8 minutes. And after we hear the pro and con, then we'll have a rebuttal from each side. The rebuttal will be presented by our fellows without any PowerPoint slides. They will be sort of off the cuff, responding to the other team's presentation. And then after the 2 5-minute rebuttals, we will go into a 5-minute question and answer session that will be led by our panel of judges. And I will introduce our judges shortly. So I'd like to really just acknowledge the hard work of our presenting teams and their mentors. I know that many of the fellows recently had board exams, and so they prepared for this during the time that they're preparing for board exams, a very stressful time. But so thank you for all the hard work that you put in. Can we go to the next slide, please? Thank you. The American Liver Foundation is celebrating its 45th year this year, so 45 years. They continue to provide a lot of opportunities to bring the liver community together through different events. You know, this event today is, we were just sort of discussing before we came online. It's a very nice event because it brings all of us who work in the area of liver diseases to really come together and for a common cause and talk about issues that we don't necessarily know the answers to and issues that affect our patients every day. And really in this climate, in the pandemic, it's very nice to bring us all together at a time where it's not really easy to do so. The American Liver Foundation continues to do programs like this that help support patients and healthcare professionals through educational programs. The ALF has seen a significant increase in callers to the ALF helpline and visits to their website, which really demonstrates the ongoing relevancy of their information and services, and continues to play a leadership role in advocating on behalf of millions of Americans who live with liver disease. ALF is a not-for-profit organization, and as such, it relies on donations to carry out its mission. So one of the other goals for tonight, other than to have fun and educate ourselves, is to be generous and support the ALF as you can. So you can see on the slide here, there are ways that you can donate. So if you are able to, I encourage you to do so. And now let's go on to introduce our panel of judges. So we have judges, a panel of 3 judges for each debate. And 2 of our judges for each debate are serving as mentors for the other debate. So you'll see them up here a couple times. Dr. Kathleen Nilles is a transplant hepatologist at MedStar Georgetown University Hospital. She is triple board certified in internal medicine, GI, and transplant hepatology. She practices general and transplant hepatology, but really has a clinical and research focus in post-transplant care. Next, we have Dr. Theo Heller, who is the chief of the translational hepatology section at the NIH. His research focuses on progression and regression of liver diseases, and also works on the pathogenesis of portal hypertension and developing therapeutics in that area. Dr. Atusa Rabi practices at the Veterans Administration here in DC, and she's the clinical director of hepatology, and her main interests include portal hypertension as well as hepatocellular carcinoma. For our second debate, we also have 3 judges. You can see Dr. Rabi has agreed to be a judge for both debates, but Dr. Sasan Sakiani is an assistant professor of medicine and board certified in internal medicine, GI, and transplant hepatology. He's an active member of the ASLD, AGA, as well as ACG. And Dr. Ruhail Kohli is an assistant professor of medicine in GI and hepatology at Johns Hopkins. He's a clinician educator, serves as the associate program director of the GI, transplant hepatology, and advanced hepatology fellowships at Johns Hopkins. So thank you to our judges. We could not do this without you. Every year, our debates are very challenging to judge because both sides always present such a compelling case and good presentations. So I don't envy you that you have to make this tough decision, but you do. All right, next slide, please. Okay, so we're going to now move on to the debates. And so the first debate centers around this question about whether liver transplant should be offered for patients with extensive isolated colorectal liver metastases. So as many of you know, most liver transplants are done for patients that have underlying intrinsic liver disease. There are certain accepted indications for malignancies in the liver, hepatocellular carcinoma, cholangiocarcinoma, metastases from GI neuroendocrine tumors. But this is a question that is a little bit more controversial and a little bit more recent in terms of the literature on both sides of this question. So that's going to be the topic for our first debate, which is that liver transplant should be offered for patients with extensive isolated colorectal liver metastases. The pro side is going to be argued by the University of Maryland, and the con side will be argued by Johns Hopkins University. Now I'm going to introduce our teams. So presenting the pro position that liver transplant should be offered for patients with extensive isolated colorectal liver metastases is the University of Maryland. The mentor is Dr. Sasan Sakiani, and the fellows representing University of Maryland are Dr. Muhammed Hammami and Dr. Ameer Abutaleb. Johns Hopkins University School of Medicine will argue the con position that liver transplant should not be offered for patients with extensive isolated colorectal liver metastases. Their mentor is Dr. Ruhail Kohli, and the fellows representing Johns Hopkins are Dr. Brian Ting and Dr. Aly Strauss. Dr. Hammami will now present the pro position on behalf of the University of Maryland.
All right, good afternoon, everyone. I'll be discussing why liver transplantation should be offered for patients with extensive isolated colorectal liver metastases. I'll start with a brief history of liver transplantation for colorectal liver metastases, then discuss the SICA trials, and finally compare liver transplantation as treatment for extensive isolated colorectal liver metastases with standard of care therapy, and compare liver transplantation for this indication as opposed to liver transplantation for traditional indications. During the 80s and 90s, multiple attempts were made to transplant unresectable liver metastases. In 1991, Mulbacher et al. Published the Vienna experience in liver transplantation for metastases, showing a 5-year survival of 12% with a recurrence rate over 60%. These disappointing results were correlated by North American data, and it was admitted that the poor post-transplantation survival did not justify using such scarce resource. Except for limited case reports, no further experience in this field were published until 2013. In the European Liver Transplant Registry, there is a record of 50 liver transplants performed prior to 1995 for colorectal liver metastases. And it is very important to note that in 44% of these cases, graft loss was not related to tumor recurrence. So when reviewing and analyzing the past data on liver transplantation for colorectal liver metastases, we should keep in mind that the overall survival following liver transplantation for any indication has dramatically improved over the last 30 years, with better expertise of transplant surgeons and post-operative management. Consequently, the first argument can be made merely based on the better expertise of transplant surgeons and improved survival rates in liver transplantation over the last 30 years. And therefore, the outcome for patients transplanted for colorectal liver metastases could be improved significantly compared to the past experiences. Additionally, through the trials I will discuss in the next slide, we have better selection criteria for patients who will benefit and have high overall survivals with liver transplantation. So starting with SICA-1 in 2013, the study looked at liver transplantation for non-resectable colorectal liver metastases. The study was planned to have very restrictive exclusion criteria. However, after a prolonged period with not a single included patient, the authors accepted a wide range of clinical characteristics, which is believed to have contributed to lower levels of overall survivability at 1, 3, and 5 years of 95%, 68%, and 60% respectively. However, The wide inclusion criteria allowed the identification of 4 clinical features to predict outcome that were integrated into the Oslo score. Using Oslo criteria, the SICA-2 trials were completed in 2020 with the intention of more selective criteria for liver transplantation of non-resectable colorectal liver metastases. The second study found better results with increased selectivity, showing overall survivability at 1, 3, and 5 years of 183 and 83% respectively. So this brings me to my second point. At present, the only curative treatment in patients with colorectal liver metastases is liver resection. However, only a small subgroup of patients is eligible for this treatment. And this is around like 10 to 15%. Non-resectable colorectal liver metastasis is a devastating disease, with palliative chemotherapy being the only treatment option for the vast majority of patients. There is a 5-year overall survival rate of less than 10% after the initiation of the first-line chemotherapy. Compared with mere chemotherapy based on the Nordic 7 trial, the improvement in the overall survivability with liver transplantation was dramatic. The 5-year overall survival rate was 60% in patients undergoing liver transplantation, and it was 9% in patients treated only with chemotherapy. So after liver transplantation, there's always the concern about disease recurrence, decreasing survival, especially given the immunosuppression that liver transplant patients require. The important note regarding recurrence is that lung-only metastasis is most common, and in both SICA trials, lung-only metastases was shown to grow slowly despite immunosuppression, and several patients could be offered lung resection with curative intent. So although disease-free survival may be low, overall survival is still favorable. Additionally, a sub-analysis of lung-only metastases suggests that the growth of pulmonary metastases is not negatively impacted by immunosuppression. And just to note, compare with SICA-1, where all patients had some of recurrence after liver transplantation, in the SICA-2, with more strict inclusion criteria, 4 of the 15 patients were observed for more than 30 months without a relapse. For my final argument, I will compare liver transplantation for colorectal liver metastases versus liver transplantation for other common indications. Understandably, a major concern of liver transplantation for colorectal liver metastases is the organ shortage across the world, and that adding a new indication for liver transplantation could negatively affect waiting lists. The universally accepted minimal survival after liver transplantation is around 50 to 70%, and survival after liver transplantation for malignancy should be equal to that as for non-malignant diseases, which is why colorectal liver metastasis is generally viewed as a contraindication to transplant. However, repeat liver transplantation is often considered for those patients with graft rejection and accounts for 5 to 10% of all liver transplantation. In the case of repeat liver transplantation, the survival rate is only 55%. So based on the SICA trials, the survivability from liver transplantation for colorectal liver metastases is higher than these indications. Additionally, marginal liver grafts, which account for 3% of harvested grafts and go unused, could in theory be given to patients with colorectal liver metastases, since these patients do not typically present with the complications of cirrhosis that would complicate such a graft for more common indications of liver transplantation. Years ago, HCC and cholangiocarcinoma were contraindications to liver transplantation. With improving patient selection, HCC now has similar overall survivability after liver transplantation as other non-malignant indications. By further developing selection criteria for liver transplantation in colorectal liver metastases, it may be possible to select patients who will obtain an overall survival rate at 5 years, similar to patients who currently receive liver transplantation as standard of care. To conclude, liver transplantation survivability has dramatically improved since the early trials of liver transplantation for colorectal liver metastases, but there has been minimal effort to reevaluate colorectal liver metastases as a contraindication to liver transplantation. Liver transplantation is shown to be a superior treatment option for non-resectable colorectal liver metastases when compared to traditional chemotherapy with dramatically increased 5-year overall survivability. With selective criteria, liver transplantation for colorectal liver metastases can provide similar overall survivability as that for other common indications of liver transplantation. Thank you.
Thank you very much. Wonderful presentation. We're going to now move on to the con side, and this will be presented by Dr. Aly Strauss from Johns Hopkins University.
Good evening, everyone. I'd like to thank the ALF for this opportunity to present for you all tonight. So what we are here to discuss tonight are 5 points as to why extensive isolated liver metastases from colorectal cancer should remain a contraindication for liver transplantation. We're optimistic for the potential of hepatic resection for more and more cancers previously deemed unresectable. We are, however, not optimistic about the extrahepatic recurrences that pose a real threat post-transplant and really call into question if the transplant was worth it. We believe selection criteria are not standardized in a way that is readily available across the US, and that the risk of immunosuppression worsening cancer can't be ignored. Perhaps most importantly, although we always want to help those in need, we can't ignore good organ stewardship in the face of organ shortage. We understand that there's a survival benefit for transplant over no transplant, but we have to weigh that against the excellent outcomes for those with other indications for transplant. So walking through these key points, let's first dive into resection. Colorectal cancer with liver metastasis is the leading cause of death in colorectal cancer patients, with an overall median survival of 6 to 12 months if not treated. And we understand this is a terrible disease and that these patients deserve treatment options. We are optimistic that resection is a viable option. Survival with resection has been shown in a meta-analysis by Canas et al. To be as high as 74%. Our definition of unresectable is evolving. In the past, only 15 to 20% of patients with colorectal cancer liver mets were candidates for liver resection. However, chemotherapy and resection techniques have improved dramatically. So have we really maximized this option? To increase the resectability rate, the effective and relatively safe preoperative portal vein embolization technique was introduced, aiming to maximize the remnant liver volume before a major hepatectomy. And further, the ALPS procedure was described in 2012 as a new approach for patients with liver tumors initially deemed unresectable. And the ALPS procedure was evaluated to convert previously considered unresectable liver lesions due to small residual liver volume into resectable ones. This picture here shows a small amount of residual liver volume that was able to be salvaged with resection. Furthermore, studies have shown that 25% of patients deemed unresectable that were treated with hepatic artery infusion and chemotherapy were converted to resection and/or ablation. So essentially, the communication between those metastatic cancer cells, the inflammatory cells, and the immune cells within and outside the liver is critical. And given all these advances we've made with other oncologic strategies that harness the immune system to target these cells and molecules have been successful, these may yield effective and durable therapeutic modalities, and we think they're in the horizon. So now let's discuss recurrence post-transplant. So first, looking specifically at just resections, not transplant, even those with small, highly selected, minimally invasive disease cancers, they still have high rates of recurrence, both in the liver and outside the liver, at 50% for each. And then if we do look at after transplant, one of the studies looking at 21 patients, the SICA study that was mentioned previously, showed a 5-year overall survival of only 60%. And all the patients that died was due to recurrence. So looking at these 21 patients, 7 of them had liver recurrence. And these were not just in the liver, they were all exclusively multi-site, and 6 of the 7 of them died. And then looking at everyone overall, 19 out of 21 had recurrence of disease. Further, in a study by Smedman et al. In 2019, they combined these 3 studies, so the SECA studies and the RAPID study, to get 43 patients and look at their outcomes for a little bigger number. And they showed that 76% had recurrence of the metastatic colorectal cancer, and 53% required chemotherapy post-liver transplant. And then after starting palliative chemotherapy for this recurrence, they had only a median survival of about 13 months, so not ideal. Looking further, we're not just talking about whether or not they get a recurrence and who survives. We're also talking about what it takes to keep them alive post-transplant. So in addition, these recurrences are found all over the body. You're looking at the liver, you're finding them in the lung, which is the most common. They found them in the rectum and lymph nodes. These recurrences require significant imaging to monitor, which are quite frequent actually. And in the study, it may not be realistic that these patients could get chest, abdominal, and pelvic CTs every 3 months and then every 6 months. And they even had to resort to PET CTs and MRIs to catch that rectal recurrence was found on MRI and the lymph nodes on PET. And then once you find something using all these modalities, you have to do something about it. So then they're getting biopsied, further resections maybe, and even further chemo. So it's starting to feel a little bit like whack-a-mole post-transplant. So one might say that we could avoid recurrences with proper selection. However, these are not standardized. So prior studies are very heterogeneous in regards to the characteristics of the primary or the hepatic tumor, previous treatments, and responses to chemotherapy. Further, these studies have demonstrated that right-sided cancers are at higher risk for recurrence, but it's not fully understood. And then lastly, certain genetic mutations have been shown to play a role in tumor characteristics. So mutations in KRAS, BRAF, and caudal-type homeobox transcription factor 2 have been shown to have prognostic value. These molecular signatures may be used in the future to offer the most effective therapies based on tumor genetic subtype. Tumor biology is missing here. So we are not at a stage where we have the criteria, something as clear as like the Milan criteria, to say that we understand how to standardize this. So let's talk about a simple but important aspect of transplantation in this population, which is immunosuppression. So immunosuppression is needed post-transplant, but known to increase the risk of cancer. And as such, the SECA group exclusively used sirolimus due to anti-neoplastic effects. However, it has a black box warning for hepatic artery thrombosis, and hepatic artery thrombosis was actually seen in 2 out of the 21 patients in one of their trials. So sirolimus is also known for a higher rate of rejection than tacrolimus, so is not as frequently used generally. So therefore, this immunosuppression may not be generalizable and able to be nimbly adopted across the US if we were to make this an indication. So lastly, organ stewardship is key when proposing major changes such as this. So we're all aware of the organ shortage in the United States. And as you can see here, when candidates are on the wait list and are followed over time, there's a pretty constant rate of death of about 10%. And about the same number that die are also removed from the list because they're too sick for transplant. So adding patients with metastatic colorectal cancer to the wait list will take livers away from those that are already dying while waiting for a liver. So more specifically, let's walk through an example that summarizes the question in front of us today. So first, let's consider we have a liver and we give it to a young, otherwise healthy patient with PSC. If we followed her survival or any other common indication for liver transplant over 5 years, we'd see that she does very well, upwards of 80% survival for 5 years. Next, let's consider giving this liver to our patient with extensive isolated colorectal metastases, who had a primary colorectal resection, received chemotherapy along with other potential treatments, and we follow his survival. We can see more than 50% risk of recurrence, and after that, a survival of almost 0 by year 3 of chemotherapy. Do we really risk giving a life-saving precious organ to someone with such high risk? So I'll add the 6th point after having gone through the facts with you, and that's that more data is needed. We aren't saying that liver transplant for this indication will never be a reasonable option, but for now we feel that larger prospective trials are needed to move forward safely for the patient not only in front of us, but the thousands of others not in front of us. Thank you.
Thank you, Dr. Strauss. Great job. So those are our pro and cons for this question. And next, we're going to move into the rebuttal. So for the rebuttal, again, we have a 5-minute rebuttal, and the trainee will not be able to use any slides for this. And first up is going to be Dr. Abutaleb from the University of Maryland, who will now rebut the Johns Hopkins University position.
Good evening, everyone, and thank you, Dr. Strauss, for your presentation on the composition. I want to address your points that you mentioned point by point. First one, that we should maximize resection as a viable option. There's no objection to that. All that we're advocating for is that liver transplant be in the existing arsenal under proper selection criteria. By all means, a portal vein embolization plus hepatectomy, the ALPS procedure, or repeated resection is an option for the patient. We should absolutely utilize it. The question of whether liver transplant is non-inferior or superior to those approaches in that particular patient population by randomized controlled trial is a question that is for another day and not the debate that we have tonight. The second point that you had mentioned was that recurrence rates are high, up to 90%, that immunosuppression can increase the chance of cancer coming back, and that extrahepatic recurrences post-transplant are a real risk. These are all very valid points. With regards to the point that the liver transplant doesn't address microscopic disease, liver transplant plus chemotherapy should be and is being tested in randomized controlled trials. Additionally, while best available chemotherapy at this moment in time may not be curative of metastatic disease, there is data to suggest that best available systemic therapy can control metastatic disease. With regards to the high recurrence rates, up to 90%, this is a phenomenon that you're going to deal with regardless of the treatment option you present to the patient at hand. Whether you offer liver transplantation or portal vein embolization plus hepatectomy, some of the other surgical approaches, you are going to be dealing with recurrence. The difference is tumor biology changes if you do a liver transplant, or so it seems. Isolated pulmonary metastasis seems to be the predominant form of recurrence in the patients who receive liver transplantation. On the other side, in the other scenario, the recurrence often seems to come in the remnant liver. As you know, in the remnant liver, we can't do anything about that other than chemotherapy and palliation. But with the isolated pulmonary metastasis, we may be able to offer curative intent with surgery. The third point you mentioned was that it can be too aggressive of an approach in end-stage disease, that liver transplant may not be the right use for this. Adoption of new treatment strategies far and away rely on many different factors, but one of the biggest things that drives all of us is the mortality difference. This is what drove us to change practice across the entire United States in the Mathurin trial for early liver transplant for alcoholic hepatitis. If liver transplant can outperform systemic therapy in the available surgical options, it should warrant serious consideration. The SICA-1 and SICA-2 trials both demonstrated very excellent mortality data and survival data with regards to this as a possible treatment option for colorectal liver metastasis. The fourth point you had mentioned was the equitable use of allografts, organ stewardship. And with regards to this, equipoise in liver transplantation is part of our job. Equitable use of allografts is part of our job, but it's not mutually exclusive to offering liver transplant for this population. Estimates by recent modeling show that this would increase the pool of liver transplant, the liver transplant pool by 1 to 2% to already accepted indications, or 0.24 to 0.51, so a quarter to a half of a human being per million people per year. So more of a drop in the bucket as opposed to a massive splash in the bucket with regards to the use of allografts. With regards to selection criteria not being standardized, there's some selection criteria that have been developed out of the SECA trials. We absolutely advocate that we should be developing further selection criteria. That's why we should be having prospective trials in multiple centers in the United States to try to validate the SECA trial data. And you mentioned that more data is needed. We absolutely agree with you that more data is needed, and we should be a part of that with the different liver transplant centers we have across the United States. A final point with regards to waitlist mortality and your argument that we may be taking livers away from people that have been waiting on the wait list. It's a very valid point, and that's why all the protocols in the United States currently are using living donor grafts for this indication. We are not taking away someone's chance for a new liver where the patient comes with their donor. Thank you very much.
All right, thank you for that. Next, we have Dr. Brian Ting from Johns Hopkins University, who is going to rebut the University of Maryland's position. Dr. Ting.
Thank you, everyone, for joining, and the ALF for giving me this opportunity to present the rebuttal position of the proposition of this argument. I will go point by point as well on Dr. Hammami's presentation. So in regards to comparison of liver transplant for CLM, colorectal metastasis versus traditional treatment for metastatic CRC, we do agree that a lot has changed in the past 30 years. And in addition to improved transplant outcomes since the 1991 study, there's much improved resectability and an improvement on that front as well with the ALPS procedure and portal vein embolization and two-stage procedures. So as when there was only 1 to 5% resectability around the year 2000, now it's up to north of 20%. So I think that comparing chemotherapy versus liver transplantation for this indication is a false choice, because it does look bad if you're committing 10%, you're committing everyone to a 10% survival rate. However, it is important to note that this is metastatic cancer that we are talking about, and the majority of patients who undergo liver transplantation for this indication still have recurrence. And the comparison of indication for metastatic colorectal cancer, which predominantly recur, in comparison with the survival of a second liver transplant, is somewhat misleading. The second transplant indication is about 3% of all patients on the wait list per year as of the 2019 data. And the majority of metastatic CRC undergoing liver transplant will recur and will not be eligible for a second transplant. And this is going to be the first and last liver transplant for all of the recurrence that we see. We are not going to do this again based on about 70+% of people that have recurrence after liver transplant. And third, my colleagues in UMD tout the SECA-1 and SECA-2 trial as a very good effort in trying to make a selection criteria. But I do want to point out that the points of the SECA-1 and SECA-2 trial is to use SECA-1 trial, which contains 21 patients, to make a selection criteria, and then use the SECA-2 trial to make that criteria more strict, using the variables obtained from 21 patients as predictive. And how can we trust this predictive scheme when the majority of these patients recur, and after recurrence, the overall survival is abysmal? To the point of lung recurrence being more numerous but indolent, I think my colleagues are trying to get at the point that disease-free survival is not the same as overall survival, and it seems like overall survival would be good. It's hard to argue that there is a difference between overall survival and disease-free survival. Overall survival will always be higher than disease-free survival by definition, but we are talking about 1 year disease-free survival of 35%, and the disease we're talking about is cancer. So if we talk about an antiplatelet agent for stroke, and the disease-free survival is 35% from stroke, but the overall survival is great, what kind of morbidity are we talking about here? And as of talking about expanding the donor pool with marginal grafts, suggesting that we expand to living donor, all these arguments are showing that our colleagues understand exactly how borderline this indication for liver transplant is. So our colleagues would seem to argue that liver transplant for this indication for metastatic colorectal cancer is warranted and is the ultimate therapy as long as the candidate selection is careful. I would argue that it does have morbidities and might have harms. So you have hepatic artery thrombosis as part of the almost universal sirolimus use in that protocol. And advocating for this type of indication here in the United States, when we don't have mature protocols and mature management of this type of indication using the immunosuppression that they use, how many bodies will we leave in the wake of this learning curve? I will just close by quoting the Norway group's own words in the discussion in their brief communication to HAT in 2020. The scarcity of organs mandate the selection of patients who benefit the most from LT. I hope we have argued thoroughly our position that with all the recurrence that we see, this is far from clear at this time.
Thank you. Now we're going to move into the question and answer period. I would like to welcome our judges. If you could join us and unmute your mics. In addition, in the Q&A, if you are an attendee, you can enter a question there, and I can go through and read some of those. But we'll have our judges, Dr. Rabi, Dr. Heller, and Dr. Nillis join us. Who'd like to ask the first question? No volunteers yet? Okay, maybe I'll ask one question to start. For the University of Maryland, we talked about, well, let me back up actually. So whenever we decide we want to transplant someone, the first one of the first decisions is that we decide that liver transplantation is the right option for them. And of course, that is a careful risk-benefit decision, which takes into account many factors, as you know. And once that decision's made, then the decision becomes, how do we get that person transplanted? And there are a lot of things that can affect that also. And in most patients, it's the severity of illness, as you know. You had mentioned that most protocols in the US for this indication involve living donor liver transplantation. But I wanted to ask you about deceased donor liver transplantation in this patient population. Is that something that should be considered? And if so, how would one go about it?
Yeah, thanks for that very good question. I think there's a waitlist mortality of 16, 17%, depending on which source is cited on the patients that are listed for liver transplant. And to make the claim that we should be favoring a patient with colorectal liver metastasis and having him bypass or her bypass the entire waitlist to get a liver transplant is not an argument that Dr. Hammami or myself are making tonight. This is why we're encouraging the use of living donor allografts. With regards to deceased donor allografts, actually the basis with which the SECA trials were initiated were due to favorable donor pool coming out of the university in Oslo. And this is what ultimately drove that study. So if there were favorable conditions where we had an expanded utility for marginal grafts that would otherwise be discarded, domino grafts, those can be utilized if they are not going to be utilized for someone already on the wait list. Otherwise, we strongly encourage the use of living donor allografts for this indication in the United States.
Thank you. Any comments on that from Johns Hopkins?
We do agree that you aptly pointed out that in Norway, because of the donor surplus, this is what drove this. And unless that changes in the United States in a significant way, I think that even marginal grafts would go to helping the people who have otherwise mainly liver indication for it. Especially when you consider the waitlist mortality there, and not to downplay the recurrence that we see in the SECA 1 and SECA 2 trials, and we just don't know what the tumor biology is going to be like. That is one thing that is starkly missing in the SECA 1 and 2 trials. Is a very homogeneous population in Norway. The United States is different, and the good outcomes that you saw is almost like introducing a selection bias in itself in the SECA 2 trials. In the SECA 2 trials, they mandated people have to wait 1 year between the primary colorectal tumor resection and the liver transplant. They have to wait 1 year or more, right? Because they found that in the SECA 1 trial of 21 patients that if you wait 2 years or more, that's a favorable prognosis. And I think that we just don't know what the tumor biology is going to be like.
Thank you. And then I have one more question for Johns Hopkins. So you had brought up the lack of standardized selection criteria for this indication. And as you know, selection criteria for transplant are determined at the center level. And there are some standardized criteria, of course, that UNOS provides for MELD exceptions, but the acceptance of a candidate for transplant is really determined at the center level. And we don't have standardized selection criteria for other indications, such as transplant for acute alcoholic hepatitis, which we debated last year. And so I was just curious on your thoughts on that, and why that still sort of plays a role.
So I think when I was discussing the selection criteria, I totally agree with your question. It's a good point that we are probably far and a long way of having specific criteria. And even if we did say them nationally, it is up to each transplant center. I guess my point was trying to get at more just a general selection of things to consider by the centers and by the providers when they are looking at a patient, things like right versus left. And it seems like right might play a role, but we need to learn more about that. And then even more impressively is the tumor biology. There's mutations that have been shown to play a role in how aggressive this cancer is going to be. And that probably plays into this idea of giving them time to show themselves, being a year or two out from treatment before we transplant them, because we don't understand the biology of what's going on. So I think thinking about it more, not as a selection committee criteria, but more just how do we risk stratify these patients? I don't think that we're near a place where we understand the biology of this tumor that, has made its way through the portal vein over to the liver, and most of the time is already up in the lung or somewhere else. And even the second group saw that when they went back and looked at their imaging. They actually had misclassified people as being liver only when they really were other places too. So I think even selecting who is really liver only mets, we don't even have clear definitions on how we work that up and what imaging modalities or biopsy modalities we need to be doing to truly know who we're even dealing with. Is this truly liver only?
Thank you. Judges, any questions?
Maybe I'll start if no one
Yes.
else has questions. I'd just like to ask Dr. Strauss, she emphasized the importance of biology in the last comments. Do we assess biology before giving FOLFOX or FOLFIRI? Do we assess biology before doing other things? You're asking for a standard of care that is way beyond common practice. Why would you be so rigorous in this setting and not in other settings?
I think that's fair. And I think sort of goes to why we're very hesitant overall is because we aren't talking about transplanting metastatic disease in other populations. We are scared of doing that because we know we don't understand it. So I think what we'd like to point out is that if this was something that we were going to delve into, we have people that have metastatic diseases from other cancers, and we wouldn't transplant them because it's metastases, even though we know that we could take them maybe from an abysmal survival rate without transplant to helping them a little bit, but you have to draw the line somewhere. And we've drawn that line for other groups of people. So if we're going to consider putting a new line in for this specific population, then we do need to be more rigorous, and we do need to understand colon cancer and colon cancer mets much better. And so, yeah, I completely agree. We would be holding ourselves to a different standard. And that's what I think we're worried about.
All right. Theo, I think we've run over our time. It's probably my fault. I'm sorry. But I'd like to congratulate both teams. You guys really did a fantastic job on both presentations, both rebuttals. I'm glad I'm not up there on the receiving end of Dr. Heller's questions. And thank you to our judges for judging this debate. It's going to be a tough one, but we'll hear the outcome at the end. We're going to now move on to our second debate. And the question here is something that gets at a liver disease we're seeing more and more of, and a type of patient that we're considering more often for transplant. So the question of transplanting patients with alcohol-related liver disease is one that has been debated for the ages. And last year, we debated whether we should transplant selected patients that had acute alcohol-associated hepatitis. And the question today gets at that patient population in a little bit of a different way, and really asks the question as to whether hepatologists should serve a primary role in managing the alcohol use disorder in these patients that have advanced liver disease. So it's really the patients with advanced liver disease. We're not asking the question of hepatologists managing this in all patients that have alcohol use disorder, but really in those patients with disease that has really progressed. And we have, we'll present both sides of these again. We'll have 8-minute presentations followed by those 5 minutes of rebuttal. And on the pro side, we have MedStar Georgetown University Hospital. The mentor is Dr. Kathleen Nillis, and the fellows who are representing MedStar Georgetown University Hospital are Dr. Veronica Nguyen and Dr. Arinda Steffi. And on the con side, from the National Institutes of Health, you will have Dr. David Yardeni and Dr. Gracia Viana Rodriguez, who will be presenting, and their mentor is Dr. Theo Heller. So we're going to now move into the debate. Dr. Nguyen will be presenting the pro position on behalf of MedStar Georgetown University Hospital. And once you have your slides up and the timekeeper is ready, we will start. Okay, so there are the slides. If our timekeeper is ready, we'll start our 8 minutes now.
Okay, good evening, everyone. I want to thank the American Liver Foundation for this opportunity to participate in this academic debate. So we are arguing that the hepatologist should serve a primary role in managing alcohol use disorder in patients with advanced liver disease. Now, the global burden of disease attributable to alcohol use is large. Harmful use of alcohol is accountable for 7.1% and 2.2% of the global burden of disease for males and females, respectively. Alcohol is the leading risk factor for premature mortality and disability among those aged 15 to 49 years, accounting for 10% of all deaths in this age group. Disadvantaged and especially vulnerable populations have higher risk of alcohol-related deaths and hospitalizations. This is data from OPTN that shows an alarming trend. With the fuchsia line, we see an increasing number of adults waiting for liver transplant due to alcohol-related liver disease. And the total number of transplant by diagnosis is also increasing for those with alcohol-related liver disease. Our societal practice guidelines just put forth updated practice guidelines on alcohol use disorder in 2019. They state referral to AUD treatment professionals is recommended for advanced liver disease and/or AUD to ensure access to full range of AUD treatment options. A multidisciplinary and integrated management of ALD and AUD is recommended, and it shows that it improves rate of alcohol abstinence among patients with advanced liver disease. EASL also recommends a bimodal approach with both counseling and pharmacotherapy, and it shows that it does reduce alcohol consumption and prevent relapse. And this is a A1 recommendation. Now, yes, there are barriers to hepatology treating AUD that our colleagues may put forth. And we may say, this may not be in our field, or there's not enough time to manage alcohol use disorder in these complex patients, or there's insufficient training. And we have to monitor for drug response and dose titrations and drug safety and side effects. We will talk about why it is important that hepatology manages alcohol use disorder. There are unmet needs related to the treatment of alcohol use disorder. In this recent study published in Hepatology in 2019, a cohort of veterans that amounted to 35,000 veterans with a new opportunity for AUD treatment. Of the 35,000, only 14% ended up having either behavioral or pharmacotherapy treatment. The American Psychiatric Association reported that less than 10% of all patients receive any treatment after an AUD disorder, diagnosis. And we know that there's benefit to AUD treatment. In the same study, they showed that with any AUD treatment, there's a decreased risk of hepatic decompensation, and there's also improved short and long-term mortality. Additionally, we know that there's widespread shortage of mental health professionals. 96% of US counties have unmet need for for psychiatrists. And there are 18% of US counties that have unmet needs for non-prescribers, such as psychologists, APPs, social workers, and licensed professional counselors. In this study published in the American Journal of Transplantation in 2020, they looked at all US transplant centers and how many offer mental health services and chemical dependency services. And actually only 85% of US transplant centers offer mental health services and 37% offer chemical dependency services. And this is alarming due to the increasing trend of liver disease related to alcohol use is increasing. Now, liver disease is a physical consequence of alcohol use disorder with severe illness necessitating frequent follow-ups, as well as the potential need for liver transplantation. And thus, hepatologists are aptly positioned to help treat underlying alcohol use disorder. There are already barriers to a pre-transplant AUD behavioral treatments. The patients are too ill, they have recurrent hospitalizations and or needing frequent medical testing and appointments. They have neurocognitive impairment due to hepatic encephalopathy, and there are logistical barriers for them to attend these behavioral therapy sessions. And additionally, they're extremely sick. They may be hypovolemic, they have dyspnea, and they're deconditioned. And so what can we do? We can start pharmacotherapy for these patients. And there are currently 3 FDA-approved medications, naltrexone, acamprosate, and disulfiram, which is not in this, this chart. But additionally, there are more studies going on for gabapentin, baclofen, and topiramate. And some of these medications are metabolized hepatically. And who better to manage these medications than hepatologists, especially in patients with advanced liver disease? We already manage many things for these patients. In the pre-transplant setting, we assess their alcohol use and relapse risk. We already do a multidisciplinary approach to get the patients to transplant listing, and we do medical management of their decompensations. In the post-transplant setting, we manage immunosuppression, and we certainly try to prevent relapse. We are already helping to treat AUD. We check in with patients frequently with frequent clinic visits. And now, especially with telemedicine as an option, we make sure that medications refills are available. We already reinforce alcohol abstinence, and we do harm reduction and counseling of alcohol use in patients. This is a proposed care pathway for AUD treatment in patients with alcohol-related liver cirrhosis. Now, medicine as a profession, we are required to maintain our certification. As everyone knows, our field is ever changing with new trials, new studies, and treatments. Physicians are expected and required to participate in activities to maintain and learn current knowledge in the field. And so we as hepatologists can certainly learn and help manage AUD. There are also a push and emerging trends to incorporate addiction medicine into hepatology education. The ASLD is actually hosting a learning course next month to talk about addiction medicine for liver providers. And there is this proposed schema that was put forth by Winters, who published this in Clinical Liver Disease last month, that proposed a way to incorporate alcohol use disorder education into transplant hepatology fellowship. And this is from our colleagues' own institution, the NIH. The NIAAA put forth the strategic plan, and in writing, they write, the quality and accessibility of care could be improved by integrating alcohol service into general medical care. And there are ongoing clinical trials from clinicaltrials.gov where they're looking at further medications to help with AUD. And of course, there's the impact of COVID-19 that has only increased the rate of alcohol use and alcohol-related liver disease. So in conclusion, alcohol use disorder is prevalent and there is a need for treatment. There's a shortage of mental health professionals, and thus hepatology can step in. There are medications that can help prevent relapse, and these medications can affect the liver. And so hepatologists are in the unique position to offer help and manage alcohol use disorder.
Thank you for your presentation. Good job. We're going to now move over to the con side, and I will ask Dr. Rodriguez to join us from the NIH, who will present the con side of this argument. You may begin.
Good evening. First, I want to thank the American Liver Foundation for allowing us to participate in this debate and all the people who is attending this debate. My name is Gracia Viana. Today, my team is Dr. Jordani and our mentor, Dr. Harrell, from the National Institute of Health, will be arguing against hepatologists serving as a primary role in the management of alcohol use disorder in patients with advanced liver disease. First, we will have to start with a common case that most of you will be able to relate. John, it's a 37-year-old gentleman with cirrhosis that presents with liver clinic for follow-up after being discharged from hospital 3 days ago in the setting of alcoholic hepatitis and new onset ascites. His past medical history is significant for depression, currently not on treatment after self-discontinuation for self-perceived lack of benefit. He suffered from alcohol use disorder since 17, has attended detox programs 3 times with multiple referrals to AA. He was sober for 8 months 5 years ago, but currently has been drinking half bottle of vodka daily. Alcohol has been around for a long time, but it was until the 1960s that epidemiological studies from Dr. Lelbach and Paginot demonstrate a strong and highly significant correlations between the daily alcohol intake and the risk of developing cirrhosis. As it was pictured in the special edition of Iron Man comics from 1979, alcohol use disorder, it's a common disorder that not even superheroes are exempted from. Currently in the US, 90% of adults have had an alcoholic beverage at some point in their life. 50% of them recognize that they have drank in the past month. Of those, 44% individuals recognize engaging in increasing risk behavior like binge drinking and 12.8% heavy alcohol use. But not everyone that drinks alcohol has an alcohol abuse disorder. Let's talk about this better. Alcohol use disorder, it's a medical condition characterized by an impaired ability to stop or control alcohol use despite adverse social, occupational, or health consequence. Currently, alcohol remains as the most prevalent of all substance use disorders in people older than 12 years old, affecting 28.3 million people in the 2020 National Survey of Drug Use. An important feature that contributes to the difficulty of success of alcohol use disorder treatment is that it's commonly associated with other substance and mood disorders. From the 28.3 million people that suffer from alcohol use disorder, 16%, 6.5 million have other substance abuse disorder. And from 37.9 million people that with substance use disorder, 15% suffer from mental illness, making alcohol use disorder treatment complex and with relative low success rate in long-term abstinence. But before discussing the key to success in alcohol treatment, let's talk about how poor of a job we are doing in treating patients with substance use disorder. Currently, only 6.5% of people have had an actual treatment. But why? The problem is not that simple. 97.5% of people do not feel that they need treatment. So our first intervention should be identifying those who need treatment and making treatment available for them. So what are the steps recommended to enhance the success of alcohol use disorder treatment? First is identifying there's a problem. That is why all medical health providers should screen and assess their patients for alcohol use disorders with the correct methods. Once alcohol use disorder has been identified, a personalized treatment plan with a professional in addiction medicine should be developed. An integrated multidisciplinary team should provide the patient with behavioral and medical assistance treatment. Lastly, patients should receive monitoring on their treatment progress. The American Psychiatric Association agrees with this approach and recommends a comprehensive and person-centered treatment plan that includes evidence-based, non-pharmacological, and pharmacological treatments. So who are the most qualified providers to treat for alcohol use disorders? According to the Liver Foundation, a hepatologist. It's a doctor that specializes in the study of liver disease. An addiction medicine doctor, it's a physician specially trained in addiction and substance-related disorders. So knowing that actually only 10% of patients with alcohol use disorder suffer from alcoholic liver disease, what should be your role as a hepatologist? Our role is to diagnose, assess, and treat alcohol liver disease and their complications. We should screen older patients for alcohol use disorder, and knowing how crucial role sobriety plays in survival for these patients, we should enroll them in treatment with a multidisciplinary group that provides them with an individualized treatment that gives them the chance of succeeding. AASLD emphasized this statement in their guidelines. Because abstinence is the single most important factor in proven survival, multidisciplinary management with addiction specialists is mandatory. Prior studies have shown the superiority of integrated multidisciplinary care in one institution compared to standard of care. Combination of psychotherapy with cognitive behavioral therapy, motivational enhancement interview, and comprehensive medical care. These studies show how integrated treatment, 28% compared to controlled treatment, have a better percent of abstinence. Because it's not just about getting alcohol treatment, it's about getting the treatment, the right treatment for you. This is an advertisement from the NIAAA. John has been battling alcohol abuse disorder for a while, and he's suffering from liver disease complication. He has had multiple chances achieving abstinence, but unfortunately, he has not been able to accomplish it. At this time, we might be reaching one on his last opportunity to save himself. So we have the responsibility of providing him with the best possible treatment to achieve his goal. On this setting, a hepatologist, we should manage his liver disease complications as best we can, emphasize the importance as key of alcohol abstinence, and contact him if possible in the same visit with our multidisciplinary team, including our psychiatry, addiction medicine specialist, social worker, that can formulate a personalized addiction plan that will let him accomplish his goal and save his life. Being abstinence is the critical important for survival. Patients with alcoholic liver disease should be referred to addiction professional to optimize opportunity for success. Success outcome correlates with disease relevant training and practice. Addiction medicine specialists are the better qualified to manage alcohol use disorder and their comorbidities. Combining comprehensive medical care and behavioral approaches has been shown to improve abstinence rates. In summary, just like you will not expect an endocrinologist to manage pancreatitis or oncologist to manage liver disease, let's stop once again minimizing the importance of substance abuse as a medical illness. Let us treat it with the respect that it deserves by referring to the correct specialist, just as we do all other medical illness. Thank you.
Thank you for that presentation, and great job. Two great presentations. We will now move directly into the rebuttal. So Dr. Steffi from MedStar Georgetown University Hospital will now rebut the NIH position. Dr. Steffi, can I have you? There we go. You may begin.
Good evening, everyone. Thanks, ALF, for setting this up and having us. And I wanted to thank the NIH fellow. She actually made my rebuttal a lot easier by agreeing how prevalent AUD is and that there is an immense lack of treatment for these patients. There's a lot of missed opportunity in this patient population. She herself stated that 16% of patients with AUD also have other substance abuse disorders, and 15% of them also have additional mental illness disorder. But what about the 84-85% that don't have that and they just have AUD alone? That's our opportunity window to treat these patients. As we all know, the last 2 years especially, there's been a increased prevalence of AUD and alcohol-associated liver disease as well. We also all know that there's a workforce shortage in providers that treat substance abuse disorders, and also even amongst those that do treat this disorder, there's a lack of comfort in addiction specialists as far as using pharmacotherapy in these patients. We know that these medications, whether FDA approved or just off-label use, they do need very close medical follow-up due to them being hepatotoxic, and also some of them needing dose adjustment in patients with CKD especially. So even if a psychiatrist was to start these medications, a lot of times they're gonna ask for a hepatology clearance to do so and for someone to follow that closely. The other point she made is that I understand that maybe psychiatrists would be the best to treat these patients, and she made the point that we don't treat pancreatitis, etc. But truth be told is alcohol use disorders and alcohol use associated liver disease is a multi-system disease, and their alcohol use is a part of this systematic illness. We do treat their AKI on CKD, we do treat their other comorbidities, so I don't think that treating their AUD would be that out of line. Like I said, we're also not nephrologists, but we do treat their AKI on CKD. There was a survey that was done regarding provider attitude as far as addiction education goes, and it showed that 89.7% of the fellows that were surveyed actually agreed that addiction medicine curricula should be included as part of their GI and hepatology training. We're not trying to replace psychiatrists, we're just trying to augment them, and therefore I do believe that hepatologists being more proactive and taking on a primary role for treating alcohol use disorder is just going to lead to better outcome in these patients. About 15 to 50% of patients post-transplant do have alcohol relapse rates. And there's also been studies done in France and Wisconsin that have showed that patients that do not receive AUD treatment post-transplant, they do tend to have less compliance with their medications and more loss to follow-up, which can lead to loss of their graft due to rejection episodes. And that's pretty much all I have.
Okay, thank you for that. Next, we'll have Dr. Yardeni from the NIH, who will now rebut the MedStar Georgetown University position. You may go ahead and begin.
All right, thank you. So good evening. And first of all, I want to thank the American Liver Foundation for giving us the opportunity to present you with our response to the arguments raised by our esteemed colleagues from Georgetown. Now, before I begin to specifically address the issues raised by our colleagues, I just want to take you back to one of the first slides you just witnessed in Dr. Graciviana's slides. And that is the cover of a very important journal, which is the November 1979 issue of Iron Man. And in this landmark issue, billionaire industrialist Tony Stark had just hit rock bottom due to his alcohol use disorder. And this outcome, frankly, is not very surprising for any hepatologist dealing with alcohol use disorder. As we all know, achieving a good outcome for these patients is extremely difficult. Now, our colleagues have shown that alcoholic liver disease is a clear and present danger. And while US mortality rates from alcoholic liver disease amongst the ages of 25 to 35 significantly increased during the last decade, and alcoholic liver disease has become a leading indication for liver transplantation, as you've just seen, we hepatologists have nothing to be proud of. Studies show that hepatologists treating alcoholic use disorder patients with advanced liver disease continue to fail time after time in achieving the primary objective, which is actually abstinence. A recent study that was published by Shari Rugal from Pittsburgh displayed an absurd number of only 14% of cirrhotic patients with alcohol use disorder were receiving a specific treatment designed to achieve abstinence. In fact, instead of reaching out to the patients and securing abstinence, hepatologists are mostly chasing the complications of liver disease and trying their luck in listing these patients for transplantations. We tap on our own shoulders with studies presenting the great outcomes we can achieve by listing them. However, many centers still avoid listing patients because abstinence was not achieved. And not surprising, there are several studies that have shown that up to 30% of patients will eventually return to alcohol. So the main fighting effort should not be in chasing down the liver complications by hepatologists, but achieving abstinence. The ASLD guidelines for the treatment of alcoholic liver disease clearly say, and I quote, "Because abstinence is the single most important factor in improving survival from alcoholic liver disease, multidisciplinary management with addiction specialists and referral to treatment for alcohol use disorder, particularly in patients with moderate to severe alcoholic use disorder or clinically evident alcoholic liver disease, is mandatory." And you've just heard from our colleagues that hepatologists should be the torchbearers for this fight because they are all aware of the ins and outs of liver disease, and there's a shortage of trained mental health physicians. We're not arguing with them. We are only saying that if abstinence is indeed our goal, we need the addiction medicine specialist to be leading the charge. We also agree with our colleagues that substance abuse should be added to the hepatology curriculum and ongoing study and furthering our knowledge of this. However, even with online training, webinars, and even a few weeks of rotation in substance abuse treatment, the hepatologist will always feel outgunned when facing an alcohol use disorder patient with advanced liver disease. And the reason he will always feel this way is because knowing how to treat and monitor addiction is not our major strength. However, for the addiction medicine doctor, this is bread and butter. So not surprisingly, a recent study in Mayo Clinic found that reduced admissions, relapses, and mortality in patients who were referred early to addiction specialists following an admission due to alcoholic hepatitis did much far better. And in addition, I want to add that statement you've just seen from our colleagues about the NIAAA. Well, that statement actually speaks about integration of care with primary care physicians. And we completely agree with this statement. However, this is the essence of multidisciplinary care and not putting the hepatologist in the center. So in conclusion, this discussion is not about the hepatologist's ability to treat a liver disease patient. It's about how to treat an addiction. And the simple answer to this question is let the addiction medicine doctor treat the addiction. Thank you.
Thank you. So those are both of our rebuttals there. I would like to welcome our judges for this debate to the screen. So Dr. Rabi, Dr. Kohli, Dr. Sakiani, as well as both of our teams. I think Dr. Rabi has the first question.
Yes, I do. Congratulations to both teams. Strong arguments, passionate arguments. I love the fire. To the NIH team. There is an ideal state and then there is real life. As somebody who practices only at the VA, I'm very familiar with real life. And you would think that we would be very good at having multidisciplinary clinics, and we're not. That's the true state of our healthcare system. And you argue that hepatologists should not be in the center, and I kind of agree with that argument. What do you think the role of hepatologists should be in that multidisciplinary clinic? Does hepatology even have a role in that multidisciplinary clinic? And if so, what is our role in that clinic? And does it should we just be focusing on patients that are post-transplant, pre-transplant, or hepatologists should be a figure in any multidisciplinary alcohol use disorder clinic, regardless of the severity of the disease?
Okay, so I'll take this. So first of all, thank you for the question, and I think that I completely agree with you with real life practice. I mean, as you mentioned, we're crashing and burning as hepatologists in alcohol use disorder. I've personally heard a former ASLD president tell me that he can't really identify an alcoholic liver disease patient if that patient doesn't admit to it, because we're not good at it. We can't really smell the patient, right? We can't really understand that there's something happening here. We don't see the clues. We're all concerned about the liver enzymes. We're looking at images. We're not good at identifying the addiction that we see in front of us, and we crash and burn time after time. So our role in this should be treating the liver complications, treating the liver manifestations when they show up. But this is winning the micro battles that are happening. In order to win the war, in order to get this patient to live longer, we need to address the main issue, which is abstinence. If you get this patient to stop drinking and avoid further alcohol drinking, that's how you keep him alive. That's how you prevent further complications. And I think this is where we fit in. We're the guys who will take care of the liver disease and not and its manifestations, and not the abstinence, where the addiction specialist will fit in and sort of lead the charge in that.
Other questions?
Yeah, I actually have a question for, I guess, mostly Georgetown, but both teams can answer. So, we heard how alcohol use disorder is becoming, it's increasing and it's becoming a major cause, and especially in the last few years. And we also heard that real world, we don't have enough specialists to deal with this and, to actually manage this well. So one question that I had was, I saw that you put in that ASLD is thinking about putting in EPAs regarding, addiction medicine training in hepatology. But at the end of the day, the people we see are a fraction of people out there with alcohol use disorder. So would you argue that it's actually better to include those entrustable professional activities in internal medicine training, which see a bigger proportion of that population as opposed to hepatology? Do you argue we should do both? What's the most optimal way to integrate that training?
Yeah, I think we have to do both, honestly, in order to be able to treat as many patients as possible. I think in the medical school curriculum, there's only 1 hour of addiction medicine over 4 years of medical education. I mean, that is insane. So I think starting even in med school, that's one place to start with, and then in respective subspecialties. So yeah, internal medicine in our case, and then that can continue into GI and hepatology.
Thank you. I think we have time for another question. Do we have one more question from our judges?
I can ask a question. I was curious when I heard the comment. Well, first of all, congratulations to both groups. You guys, it's obvious you put a lot of effort into your work, and I love the enthusiasm you guys put in. I had a question, I guess more towards Georgetown. You mentioned the fact that the medicines that are prescribed have potential hepatotoxic effects. Quick glance over at liver tox. There seem to be like D's and E's as far as the risk. But there is, known risks, especially with like medications like naltrexone. I had a question. So these medicines that have potential hepatotoxic effects, should it be the hepatologist to prescribe them when there's so many other medicines out there that also have hepatotoxic potential?
Yes, I think the hepatologist actually would be the best person to be prescribing and monitoring these medications, because also in the pre-transplant population, we already get consulted for elevated liver enzymes. We have to evaluate whether or not it's DILI in certain patients. And of course, patients with alcohol use disorders can certainly have DILI. And then in the post population, we are constantly looking at liver enzymes and making sure that their immunosuppression is adequate, whether it's rejection. And then if they are on any of these hepatotoxic medications, it would be us to best evaluate whether it is rejection or drug-induced liver injury. And so, I would say, who better than us to manage and prescribe these medications when they have liver effects?
All right, thank you. That takes us to the end of our question and answer period. So our judges are going to now go off screen and deliberate and make some very difficult decisions. Two really excellent debates. But I look forward to seeing what they come up with. I would like to express our deepest gratitude to the national sponsors for their support of tonight's event. This event takes a lot of planning and a lot of effort on the ALF side, and it really could not be possible without the sponsors. So I'd like to thank our national gold sponsors, AbbVie and Eisai, our national silver sponsor, Salix, bronze sponsors, Alexion, Mallinckrodt, and Pfizer, and the national expo sponsor, Exelixis. And lastly, one more plug. Remember, the ALF is a not-for-profit organization, and they're really kept alive by your generous donations. And so we are very grateful to anyone in our audience who's already taken a moment to donate. If you haven't, if you look in the question and answer box, there's a link there. You can make a donation, and as they say, no amount is too small. So we'll just maybe pause for a few minutes there if people want to take a look at the question and answer box. And while you're doing that, I'd like to make just a few closing comments here. This was really a tremendous evening. I'd like to congratulate all of our teams on a really outstanding job. All of the debates, both sides, were very well researched. They were very well presented, passionately presented. And one of the things that's so nice about the academic debates is nice and challenging, I would say, for the debaters, is that sometimes you have to present something that may not actually be your personal view, but you have to research it and come up with evidence, and then on your feet argue for it based on something that the other side may put forth. So you have to also think ahead. But our fellows really did an outstanding job. I'd like to thank their mentors for all of their expert guidance, the judges who had thoughtful questions, and then the ALF tech team who really helped this run smoothly. 2 years into the pandemic now, we've all gotten used to Zoom and WebEx and Teams and Google Meet, probably some others. But it's always difficult to get this off without a hitch when you have so many people joining. I think we have, I see a total of 70 participants online. So what a tremendous turnout. In the future, the ALF is going to continue to host academic debates across the US. The next one will be December 9th in Michigan. And so if you would like to register for that, being virtual, you don't have to be in Michigan to attend it. You don't have to fly there and brave the snow. You can be here in the mid-Atlantic, hopefully with our good weather. And then in March, I'd like to alert you to, there's going to be an event that is going to take place in March over several days that will field debate teams from across the US. So we'll have multiple days of academic debates. So if you are interested in that too, you can look at the ALF website. You can always reach out to me. I can connect you if you're interested in putting together a team or interested in being a mentor advisor for that. So that's coming up. That's something new that the ALF is doing next year in 2022. And lastly, I'd just like to remind you to visit the ALF website, recommend it to your patients and your colleagues. There's a lot of good resources on there. I see in the chat the website, as well as the helpline for patients, is available. So you can explore that. There's also a list of the different events that are coming up through ALF. You can also reach ALF through social media by liking us on Facebook or following on Twitter and Instagram. So now we are getting towards the end here to announce our winners. So first of all, thank you to everybody that participated. We have to declare a winner. Though there is really no winner or loser here. As I said before, both teams really did quite well. And so the first debate was around whether liver transplantation should be offered for colorectal, extensive isolated colorectal metastases. And that was between the University of Maryland and Johns Hopkins. And according to our judges, the winner of that debate is Johns Hopkins. So congratulations to both of you. The second debate was between MedStar Georgetown University Hospital and the National Institutes of Health, surrounding another very important question about the hepatologist's role in managing alcohol use disorder for patients that have advanced liver disease, something that we are all grappling with now on a near daily basis. And the winner of that debate is the NIH. So congratulations to you, and congratulations to all of the teams. And that just about brings us to the end of our night. We were actually scheduled to go to 8 o'clock. It is only 7:35, so I'm going to give you back some of your evening. And since we were not able to serve you dinner like we were 2 years ago, you can hopefully grab something to eat now. And hopefully we'll see you next year. Thank you for joining.